So hi everyone that's joining. Welcome to this final crash course series on ENT. Today we've got Izzy Brooks, who's an F2 working in London, and she's going to go through some questions and some cases with you. And Izzy, I'll let you introduce yourself.
Yeah, hi everyone. I'm Izzy. I'm SH at Ealing. I'm going to cover ENT today, mainly kind of single best answer, and then a bit of explanation about what to look out for in questions. If you pop answers in in the chat, and if you have any questions along the way, I'll keep an eye on the chat as well, and do my best to answer them. Yeah, let's get started. If this will work. So your first case is a 60-year-old lady who comes to you at the GP. She's got a background of hypertension and heart failure, and she's on ramipril and furosemide. She's had 2 weeks of progressive hearing loss, and she has also had occasional episodes of tinnitus with that. She's otherwise systemically well, and you have a look in her ears, and both tympanic membranes are intact. She can't see any abnormalities. You do a Rinian Webers and find that air is conducting greater than bone bilaterally, and there is lateralization to her left ear. So given that history and examination, what is your most likely diagnosis? If you can either type the answer in the chat or just put A, B, C, or D.
We're going to go through the answers as well, guys. So even if you're not sure of the answer, just have a go, and then we'll go through it in a moment.
Any takers for any answers there? I will go through it.
Yeah, we've got a couple of A's coming through now and a D.
Okay, so what you would be thinking is actually C, an acoustic neuroma. Reason being, she has got a sensory neural hearing loss, which is unilateral. So that is a red flag and a tumour until proven otherwise. Going through the other answers, so ototoxicity is, yes, something you'd want to think about, because some of you would have correctly spotted she's on furosemide, which can cause ototoxicity. It does cause sensory neural hearing loss, tends to be variable in presentation. There aren't sort of, in the literature, there isn't particular clarity on exactly how it would present. And those are the main drugs that you'd think about. But in someone of her age group with sort of a progressive sudden onset sensory neural hearing loss, which is unilateral, you'd be wanting to rule out a tumour. With otosclerosis, that's usually in younger patients and it's usually hereditary. So someone else in the family would have it, and it's a conductive hearing loss rather than a sensory neural hearing loss, and it's bilateral. You'd have a normal examination otherwise, and they can have vertigo and tinnitus with it as well. So acoustic neuromas and vestibular schwannomas, they are what you think of if there's any red flag symptoms. So a unilateral sensory neural hearing loss like she had, plus or minus tinnitus, which again she had as well. They're benign tumours, but they usually get excised because as they grow, they can have neurological problems. And you do an MRI, and that is what you would see on an MRI. Those arrows are pointing to quite a large acoustic neuroma there. And then presbycusis, which is just aging hearing loss, normally bilateral, and you lose your high frequencies first, which you see on an audiometry, which is shown here. So sometimes in finals, they give you an audiometry and they ask you to interpret it. So that you can see both ears are doing the same thing, and it's lost at their high frequencies, which is what you would expect in presbycusis. So next case study is you see a 35-year-old female who's got sudden onset dizziness When you ask a little bit more, she says that she feels the room is spinning around her, and it's been going on for about 2 days. She'd had a mild upper respiratory tract infection 5 days before, and you suspect she probably has vestibular neuronitis, which symptom, A, B, or C, isn't consistent with a diagnosis of vestibular neuronitis.
Great.
Yeah, seeing some Bs. So excellent. Sensory neural hearing loss is not associated with vestibular neuronitis. It doesn't affect nerves, as in sensory neural hearing loss nerves. So you would expect it in labyrinthitis, but you wouldn't in vestibular neuronitis. They present fairly similarly, but that's how you would distinguish between the two. So if you see a patient with true vertigo, so the room's spinning around them, you want to differentiate whether it's been a peripheral or a central cause. Peripheral tends to be a bit more common. BPPV you see a lot in GP, and that's crystals within the labyrinth that cause them to get short attacks of vertigo, usually when they turn over in bed. And you do the Epley maneuver to both diagnose and treat it. Labyrinthitis and vestibular neuronitis, usually following a upper respiratory tract infection, attacks of vertigo that last, they're bedridden, they have nausea and vomiting, and it just takes about a week to settle down, and you can give them some prochlorperazine to try and help treat the vertigo. Meniere's disease tends to be a diagnosis of exclusion because it's fairly rare, and it'll go to sort of tertiary centres to get diagnosed. They have several attacks of vertigo with stepwise sensory neural hearing loss, but recover in between. And then your central causes, if you see anyone with a new true vertigo, you want to make sure you're ruling out a stroke. So a posterior stroke can cause vertigo and not a lot else. And then you have things like migraines, tumours and epilepsy as well, which can cause it. Tinnitus basically comes on with any problems with hearing loss or vertigo, so it's quite a difficult one to give you a pure tinnitus. Often it's physiological, or because they've had some really loud music or something like that, you can get tinnitus. But you can see there's a long list of reasons that you can have tinnitus. Sometimes it can be useful to characterize them between objective, pulsatile, bilateral and unilateral. If it's bilateral, it's almost always physiological, and you can reassure them and give them coping strategies, and often psychological support as well if it's ongoing. And then unilateral, you should be thinking about investigating for a tumour if there's no obvious other cause like a labyrinthitis.
I think, Izzy, we've just got a question in the chat about acoustic neuromas.
Yeah.
Is there a particular pattern of sensory neural hearing loss associated with it, e.g. high frequency or across all frequencies?
It's normally on audiometry, it's normally sort of all frequencies. It's not just a high frequency like you see in presbycusis. So yeah, and it would only be on the one side. So you'd be able to see that on an audiometry. So next is you see a 15-year-old male with a 3-day history of ear pain. You have a look in his ear and you see this. Given the most likely diagnosis from this, how are you going to treat this patient? So this is rest and reassurance. you've got acute otitis media, which is self-limiting disease. You see it very, very commonly. You only prescribe antibiotics if they're young or systemically unwell. Drops aren't going to permeate through the tympanic membrane, and it's a middle ear infection. And you can give oral antibiotics, but again, that's only if they're young. Red flags to look out for, which you would suspect that it may have spread, is if you're seeing sepsis with post-auricular swelling, so you're worried about a mastoiditis. If you see any cranial nerve palsy, is normally a facial nerve palsy. Any symptoms of meningism or an altered GCS, you're going to admit them under ENT for any of those red flags. So you see an 85-year-old female with 4 days of ear pain and discharge. She feels her ear is swollen. You have a look in her ear and you see this. You take an ear swab and you send it off. Which organism would you be most worried about growing from the swab? Yeah, good, seeing lots of bees. So Pseudomonas, both Staphylococcus and Pseudomonas are the two that you'd most commonly grow. But Pseudomonas is, you would be worried about it turning into necrotizing otitis externa or malignant otitis externa. They're the same thing, but people, sometimes you hear them both names. If a patient grows Pseudomonas and has signs that they might have necrotizing otitis externa, they need to be on long-term IV antibiotics. Otherwise, this is just an otitis externa, which you treat with usually a combined antibiotics and steroid spray for 7 to 14 days. You advise them on keeping their ear dry and not sticking cotton buds in it, which often causes both trauma and also infection. And your red flags, which would also make you think of before your swab comes back as Pseudomonas, if there's any facial nerve palsy. So if you're doing an ear examination, you should usually be doing a cranial nerve examination as well. If there's any cellulitis of the surrounding pinna, or if there's complete stenosis of the ear canal, so you cannot see down, then you would want to be referring into the hospital. If there's complete stenosis of the ear canal, that's not always always an emergency, but they often, because you cannot put steroid drops down the rest of the ear, they have to put a small sponge, which is called a Pope wick, which you then soak in steroids, which reduces that swelling. Okay. So out of these 3 lovely looking tympanic membranes, which one would you say is chronic suppurative otitis media? And for bonus points, if you want to name all of them, go for it. I will cover what they all are. Got a B and a C. Any other answers? So chronic suppurative otitis media is B. A is your cholesteatoma, so it's the keratinizing squamous cell, commonly seen as a tumor, but it basically eats in through your tympanic membrane in the attic, which is a small pocket. They can treat it either by microsuctioning it to what they call microsuction to dry. So they try and remove all of the debris and the cells there. Or if it has invaded into any of the local structures, then it needs surgery for removing and repairing the tympanic membrane. B is your chronic suppurative otitis media. It's likely that they've microsuctioned this before they've taken a photo because there's actually not a lot of fluid coming out, but the tympanic membrane isn't inflamed. You can see it's slightly retracted, and then there's a nice hole within the tympanic membrane, which you see with CSOM. C is acute suppurative otitis media. The difference between B and C being it's acutely inflamed, which you wouldn't see in a chronic suppurative otitis media. So next, you have a 6-year-old man who comes into A&E with a nosebleed. It's been going on for 30 minutes despite appropriate first aid. He's not on any anticoagulation and hasn't had any trauma to his nose. When you have a look in his nose, what is the name of the area that's most likely to be bleeding? Lots of B's, yeah. So it's Little's area. So it's got lots of small vessels that are very friable. It's very anterior in the nose. It's more likely to be bleeding, and especially if people's noses are very dry, it makes it more likely to bleed. Normally you see it in elderly patients. They tend to have very dry mucous membranes and get lots of nosebleeds. They're also more likely to be on anticoagulation. The rarer causes to look out for are hereditary hemorrhagic telangiectasia. These patients are usually younger. They're usually really well known to A&E because it's familial. One thing for you to remember if you're working in an A&E is never pack a nose. If someone has HHT, it causes more trauma to the mucosa and they're more likely to keep bleeding. Juvenile nasopharyngeal angiofibroma is a benign vascular collection that you might see with lots of unilateral bleeding, recurrent nosebleeds. If you do an FNE, so fine nasoendoscopy, you might see a collection tumour there, and then you do an MRI as well, and that will need surgery, otherwise it will just keep bleeding. And any sinonasal neoplasms as well can cause epistaxis. So something that's unilateral and constantly constant presentations, you would then want to do some sort of imaging or have a look to see if you can see any tumours there. So you see a 50-year-old man who comes into your GP with blocked and runny nose for 11 days. He has a headache and a sore throat, but he doesn't have a fever. He's otherwise systemically well. Which of the following would you not consider prescribing him? Yeah, good. Lots of C's. So topical antibiotics very rarely used for any kind of rhinosinusitis. Oral antibiotics are also not very commonly used. Nasal decongestants are good for symptoms, and nasal corticosteroids are also useful if there's mucosal edema. Antihistamines can be used, especially if it's a rhinitis, usually an allergic rhinitis, and if they're sneezing a lot, things like that, that can be helpful. Common causes for a blocked nose is something that you get people coming into the GP a lot about. Just rhinitis is just inflammation of the nasal mucosa. lots of sneezing, itchy, runny noses. Usually it's allergics. You see people with hay fever. You can do allergy testing, and antihistamines are useful. Acute rhinosinusitis is more including the sinuses. They get facial pain, lots of discharge. You might have a look up the nose with a thudicum and see quite a lot of edema and mucopollar discharge. Sometimes you see polyps kind of bilaterally. They usually get better about 7 days to 10 days. And you can prescribe them decongestants or nasal steroids to improve that. Chronic rhinosinusitis is quite a difficult treatment. It's over 12 weeks of blocked noses, discharge and facial pain, and you'll see these patients coming back and back again even after lots of nasal steroids. You have to give 3 months of good treatment, so nasal douching and nasal steroids before they go to ENT to consider kind of higher level treatment or any surgery. And then polyps are another cause of people coming in with blocked noses. So they're just swellings from the nose or the paranasal sinuses. If they're bilateral, it's usually less worrying. It's usually inflammatory. They've got a history of rhinitis. If they're unilateral or bleeding, then they're going to need a biopsy to check that it isn't cancerous. And you can prescribe things like antihistamines and nasal steroids to try and reduce the size of the polyps. So spot diagnosis, you see this in A&E, have a look up their nose. What is this? Yeah, very good. Septal hematoma. So it's something that you should be very aware of, especially on a Friday or Saturday night, people coming in with broken noses, things like that. This they will need to be admitted for, as they need incision and drainage to prevent the cartilage breaking down. It's very common. You see a lot of people coming in with broken noses. 40% of all facial injuries are broken noses. Before you do anything else with the nose, you need to check for things like facial fractures. If they've got any diplopia or facial numbness, that's more important. If they've got any other head trauma, then they need a CT head and fixing any lacerations. The nose will be very swollen when it's first broken. So normally manipulation of the fracture happens 5 to 7 days post the injury in an ENT clinic. That used to be always done under GA. Since COVID, a lot of the time it's done under local anaesthetic now, and I think that's going to be the practice more going forward. Your red flags in any nasal trauma or facial injury is things like the septal hematoma, if they have persistent epistaxis, or if they've got any signs of a basal skull fracture. So CSF, rhinorrhea, battle sign, raccoon eyes, anything like that. You're going to get them a CT head and get a neurosurgical opinion. Which of these symptoms is not included in your impending airway disaster triad? So this answer may surprise some of you. So it's actually D, stridor. So your impending airway disaster triad is before you actually get to the airway disaster. If the patient is stridulous, it's a late sign of airway compromise. You're already worried and you should have the airway team at that point because they've not got a lot of air going through their trachea. So severe dysphagia, croaky or hoarse throat, and tachycardia, or any kind of signs of sepsis, so tachycardia, tachypnea, or high fevers, that's all within your impending airway disaster triad. So if they're stridulous, get help immediately. So you see a 22-year-old lady coming into A&E with a severe sore throat, pain on swallowing and fever. You hear stridor, she has a hoarse voice and is drooling. ENT and anaesthetic team are with you. You've started IV antibiotics, IV steroids and humidified oxygen. Given the likely diagnosis, which bacteria is the cause of her presentation? Got some A's and got some C's there. So I'm hoping you're all recognizing this as epiglottitis. Most common cause is Haemophilus influenza type B. This commonly was associated with children, but given the Hib vaccination, it's becoming rarer. We are seeing it again in young adults, often smokers or immunocompromised diabetics, but Hib is your cause of epiglottitis. Any toxic patient, which is a drooling, septic, stridulous patient, it's epiglottitis until proved otherwise. And don't look in their throat until you have an airway team present, and then they'll usually do an FNE, and you see this, which is a very swollen epiglottis. They should have high flow humidified oxygen, IV steroids immediately, so dexamethasone 8 milligrams. Start the SEP66 and do nebulized adrenaline. Some places you can also do nebulized dexamethasone as well, but that's less commonly done. So you see a 15-year-old man with a 3-day history of a sore throat, pain on swallowing, and a fever of 38.2. You have a look in his throat and you see this lovely picture. Are you going to start antibiotics for him? Yes or no? Good, yeah, we've got some yeses. So this is tonsillitis. Most causes are viral, 70% of them, 30% are bacterial, usually group A strep. And it's normally over in about 7 to 10 days. You would treat the 30% that are bacterial with Pen-V. And if there's any signs that they can't swallow things like fluids, if they're unable to swallow anything, or if there's any breathing problems, then you can give them some dexamethasone, which should help reduce the swelling, and then they can go home once they're able to swallow fluids, and importantly, swallow pain relief. So good pain relief is key for tonsillitis. Deciding whether to prescribe antibiotics or not, you can either use the Centaur or the fever pain criteria, which you guys are probably quite clued up on given you're doing finals, and that's a common question. So I'm just going to leave that there. You can have a look at it. So you now see a 15-year-old boy with a 3-day history of sore throat, similar presentation, so sore throat, pain on swallowing, and a fever of 38. He then tells you his sore throat is mainly on his right side, and he feels his voice sounds quite thick, he struggles to open his mouth for you to examine, what from supraglottitis, laryngitis, or peritonsillar abscess, or Ludwig's angina are you thinking that he has? Good, yeah, C, so peritonsillar abscess. So it can come together with tonsillitis, so they might have a couple of days history that sounds like a tonsillitis, but the right-sided and the hot potato voice and trismus, so difficulty opening a mouth, makes you suspect a peritonsillar abscess. That is what you'll see. So one side of the tonsils looks much more pushed over, and you can't really actually see the tonsils there. So supraglottitis would be an airway emergency as well. They would be much more septic, drooler and stridulous, similar to epiglottitis, and the management is the same. Laryngitis is just kind of your regular sore throat that will get better with sword, gargles, reassurance and time. Peritonsillar abscess is a semi-emergency. It can develop into an airway emergency if it goes down into a deep neck space infection. They'll have a unilateral sore throat, hot potato voice, and odonophagia. You want to aspirate the pus, give IV antibiotics, IV steroids, and usually observe for about 24 hours after you've aspirated the pus to make sure that hasn't recollected. It's also called a quinsy, but peritonsillar abscess is more anatomically correct. And then Ludwig's angina can also develop into an airway emergency. It's bilateral cellulitis of the floor of the mouth, and it's usually a dental cause. So there should be non-call dentist at most A&Es, and you're going to treat them with antibiotics and watch them to make sure that it doesn't develop into an airway emergency. So when you think about causes of airway obstruction, a good way to think about it is your intraluminal, intramural, and extramural. So foreign bodies and tumours can be sitting in your airway. You can get angioedema or infection, basically causing your intramural to swell and obstructing your airway, or you can get tumours and neurological causes, which are extramural, causing your airway obstruction. Pretty much all of them, you will want an airway team there to intubate in case, and if things go really wrong, then you may have to take them to surgery. So the kind of steps in an airway obstruction is give them steroids, give them nebulized adrenaline, give them oxygen, make sure they keep them calm, especially if it's a child, and secure the airway, either intubating them or doing tracheostomy, which can be percutaneous or surgical. Tracheostomy is actually not very long surgery. It's about 35 to 40 minutes. Make horizontal incision down the throat, divide down the muscles until you see the tracheal ring, and then you make a window past the tube through it, and you have a secure airway. At that point, you tend to tidy up what's happened because it's been an emergency and there's a lot of blood everywhere. Your airway emergencies. So you have a 70-year-old lady presenting with a hoarse voice lasting for about 4 weeks. She hasn't seen any improvement. She otherwise feels well and has no other symptoms. If her etiology is due to a nerve dysfunction, which nerve is going to be involved? Yeah, good. Your recurrent laryngeal nerve innervates your vocal cords. So they're used to regulate your airflow through your larynx to create vocal pictures. There are several causes of hoarseness. You've got viral causes like laryngitis. They usually improve by about 2 weeks. Tumours strokes or other neurological disorders, and post-surgery or post-intubation or post-neck trauma. Red flags to watch out for is hoarseness or voice changes for more than 2 weeks, any difficulty in breathing or swallowing, or ineffective coughing. So that's what your normal vocal cords should look like when they are open. That's your normal ones closed in the middle, and then on the right hand side you can see a right vocal cord palsy, so it's not coming into the midline, and they won't be able to make proper noises through that, but they will obviously still be able to breathe. So moving on to salivary gland disorders. So you see a 60-year-old lady who has come in with painful lump over her cheek for the last 2 days. She's felt rather unwell as well for a few days, noticed the pain was worse after she'd eaten, but is actually present all of the time. You can't see any facial nerve palsy. You have a look in her mouth and you see pus coming out from a duct. Which duct would it be, given that this painful lump is over her cheek? So this would be Stenson's duct. That comes from your parotid gland. Wharton's and ductal rivinus is from your sublingual and submandibular, and obviously cystic duct is coming from your gallbladder. Stenson's duct is also the most likely one that you're going to be seeing pus from because it's a slightly larger opening and easier to see in the cheek. So different disorders in the salivary glands. So you can have sialadenitis, which is just acute inflammation of the salivary glands, which is what the lady in the case study have had. You have pain and swelling and pus associated with a fever, and you're giving antibiotics, rehydration, and good oral hygiene. Sialolithiasis is they get a stone in the salivary gland. Usually these patients have been dehydrated or they're on antimuscarinic drugs, which reduce your saliva. They get postprandial pain when obviously your salivary glands are most at work, and they get swelling from that, but they will be systemically well. They can often have a history of recurrent inflammation of their salivary glands, and to treat it, you give them lots of fluids and sialologs to stimulate the glands to try and move the stone along. If you can palpate the duct, then sometimes you can try and almost milk it out, but they can be quite large. Sialectasis is stenosis of the acini, which forms cysts, which is just coming off of the ducts. There's not really a known cause for it, and they can calcify as well. So the treatment is surgery, so you remove any calcification, and marsupializing the duct basically means it comes out as more of a pouch, so you open it up into the cheek. Parotitis is inflammation of both your parotids. Usually it's bilateral, but it can be unilateral. Common things are things like mumps, which is getting more common due to decreased uptake in the MMR vaccine. Bacteria, fungal is very rare, but would be candida if it does get infected. And then you've got systemic things like sarcoid, which you can see as well. So you see someone with a salivary gland tumour. What's the most common type of salivary gland tumour, taking into account both benign and malignant? Yeah, lots of Bs. So pleomorphic adenoma is your most common salivary gland tumour. They usually present with painless lumps and swellings over the affected gland, commonly the parotid, with a dry mouth due to dysfunction of the gland. Your red flags are facial nerve palsy, so whether it has infiltrated into the facial nerve, if there's any ulceration that you can see either on the inside of the mouth or on the cheek, and if it's painful. You want to do a CT or MRI to have a look, and it'll need a cytology analysis as well. So your benign tumours are your pleomorphic adenomas, that's 60 to 70%. They're usually female, and there's a mixture of different types of cells within it, hence pleomorphic. Warthin's tumour is fairly rare. It's mainly in males, smokers, and it's bilateral, and cytology will be showing lots of lymphocytes. And then you've got your 4 most common malignant ones as well. Mucoepidermoid is your most common and also mostly found in females. Actinic cells, which you can see most of these are in parotid tumours. Actinic cells also in females. They can be bilateral, and they tend to grow slowly. The adenoid cyst is the commonest malignant. Although the mucoepidermoid is what you find 90% in the parotids, but actually adenoid cyst carcinomas is your most common malignant tumour, presenting slightly younger, sort of 40 to 60 years, with pain and facial nerve palsy. And your adenocarcinoma is 2.5 to 4% of all parotid tumours, very malignant and a very poor prognosis. You see a 55-year-old with recurrent ulcers, who's noticed a reddish plaque in his mouth. Not particularly painful, but it's been there for 3 weeks. You have a look, and that's what you see. What do you call this? Yeah, so this is erythroplakia. Chronic aphthous ulcers are usually a bit smaller, and yeah, not so angry red looking, widespread. So this would make you suspicious of erythroplakia, which is one of your red flags for a SCC of the head and neck. It can come in any SCCs, basically it can originate any mucosal surface in the oral cavity, pharynx, larynx, or paranasal sinuses, and it's classified by where it arises. So an oropharynx SCC or a nasopharynx SCC, etc. Are usually caused by tobacco or alcohol or immunosuppression. Some viruses, so HPV and EBV, can make you more at risk. Any radiation previously to the head and neck, and particularly salty processed foods. So if any of these are present for longer than 2 weeks, that's a red flag, and you should be thinking about getting a biopsy or some sort of imaging. So a non-healing sore, any dysphagia or pain on swallowing, any hoarse voice, erythroplakia or leukoplakia. Leukoplakia is similar to this, but white. Any of these, along with kind of tinnitus or sensory neural hearing loss, or blocked sinuses as well for more than 2 weeks. So these will just be some quick case studies that I want you to match to. So if you want to write 1 and then the letter, and 2 and then the letter. So first one's a 22-year-old lady who comes in with swelling in the midline of her neck. She is concerned as her mother had thyroid cancer. You examine her and she has a smooth fluctuant mass that rises when she sticks out her tongue. And the second case is a 65-year-old gentleman who has a swelling in the lower third of the anterior triangle. He also complains of dysphagia and reflux, and the swelling you can feel is soft, and when he swallows, there's a gurgling noise. Yeah, good. So one is a thyroglossal cyst. So there's a remnant of your thyroglossal duct that can swell. It's found in the midline and it rises up when you stick out the tongue. It's benign and you can reassure them. If it's cosmetically worrying, you can get that removed and repaired. And 2 is a pharyngeal pouch. So often in elderly patients or older patients, it's an outpouching, and it can collect food and make this horrible gurgling sound and cause lots of reflux and things like that. You would do a OGD to see it, and you can repair them if they are large and troublesome. So there's a next one is a 2-month-old with swelling in the middle half of his sternocleidomastoid. It's firm and the patient can't turn his head. Mum thinks it's been like this since birth, but she's just starting to worry her at the moment. The next one is a 40-year-old lady who comes to your GP with 6 months of a painless pulsatile mass at the angle of her jaw. And the last is a 2-year-old who comes with a large left neck swelling, which is soft and painless, but it's causing some respiratory distress. His mum thinks it was present at birth, but it's gotten much larger in the last 3 weeks. To the question from Joel, yes, you can do a barium swallow as well. You would see obviously collection of the contrast within the pouch. OGDs can be useful to just have a look within it as well, and assess how large and where exactly it is if you're thinking about doing surgery. Okay, so number 3 is a sternocleidomastoid tumour. Despite the name, it's not actually a tumour. It's often caused by a traumatic birth. So you'll see usually sort of below the age of 4 months, the muscle is essentially in spasm and their neck is twisted towards it, but their chin is turned away. It's called torticollitis. Basically, they can't turn their head properly. And giving things like muscle relaxants and stretching the muscle is more useful. So it's not actually a tumour, and you can reassure mum of that. Number 4 is a chemodectoma, which is also known as carotid body tumour. It's collection of vasculature that would need operating on, depending on the sort of background of the patient. It can arise anywhere along that chain as well. It's not always next to a carotid body tumour, but from that presentation, you'd think it's a carotid body tumour. Number 5 is a cystic hygroma. So this is a cystic outpouch in the lymphoid system, often present at birth, can get larger and doesn't always necessarily need surgical repair when they're young, but if it is getting bigger, and it can cause respiratory problems if it's excessively large, and can also get infected at those points, you would want to start thinking about surgery. But they can be very large, and parents often want them repaired, but it's not a malignant tumour. So head and neck lumps, when to worry. So if you see any erythroplakia, leukoplakia, or non-healing ulcers, you'll be thinking of SCCs in the oropharynx. If you see anyone with unilateral blocked noses, recurrent unilateral nosebleeds, tinnitus, or sensorineural hearing loss, you're thinking about SCCs in the nasopharynx. An irregular fixed hard midline lump, you're thinking of thyroid cancer. I know Ash did a session on which she covered more about the thyroid. Painless persistent cervical supraclavicular lumps with hepatosplenomegaly and B symptoms, you'd be thinking about a lymphoma. And any dysphagia or hoarseness more than 2 weeks, or any respiratory compromise, you can think about any head and neck cancers basically that has locally invaded. So snoring, quite a common presentation. Often the partners come with them to complain. So you see a 35-year-old gentleman who's come because his partner is bothered by his snoring. He's overweight, he's a smoker, and drinks alcohol mostly on the weekends. Which of the symptoms below would not be diagnosis of obstructive sleep apnea? So you shouldn't see breathing difficulty in the day with patients with obstructive sleep apnea. If they are actually having breathing difficulty, you should be worried that there is something that is actually obstructing the airway. With obstructing sleep apnea, the tongue or the epiglottis can flop backwards, which is what's causing it. But during the day in alertness, they should be breathing fine. So mainly they'll complain of daytime sleepiness and snoring. I'm not entirely sure of the pathophysiology in nocturia, but that is a common symptom that you'll also see. So you diagnose him with likely obstructive sleep apnea. Prior to deciding on the treatments, you refer him for some sleep studies. How many apneic episodes would you expect to qualify him to use CPAP? So you would be looking at 20 an hour, so 15 to 30 an hour puts you at moderate OSA, and that's normally when patients will start presenting with daytime sleepiness or daytime symptoms. above 30 an hour is more severe. And you also have the risk factors being age, male, obese, smoking and alcohol. So he had all of those risk factors as well. Treatments as lifestyle if it's mild, so losing weight, stopping smoking, reducing alcohol. You obviously can't reduce your age. You would then start them on CPAP, and that's the mainstay of treatment. Surgery is reserved if it's severe and it's just not responding with CPAP. So uvulopalato-pharyngoplasty is your most common one. So they're just opening up the back of the airway to try and reduce that collapse of the upper airway basically during sleep. And then you can also get maxillofacial multi-level surgeries, but those are very rare. And I've worked at a quaternary ENT session, and I didn't see anyone getting that kind of treatment for OSA. Yeah, thank you. Any questions? It was a very quick tour of most of ENT.
Thank you, guys. If you could all fill out the feedback form for us, that would be really helpful, and just helps us to improve future sessions and gives us some feedback as well. And we can send you the slides. You get access to the slides once you've done that form. Thank you very much, Izzy.
No problem. Everyone have a lovely evening and good luck with finals.